The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our Safe and Calm COVID webinar for September 16. This is Deanna Mitchell from Leading Age Michigan, and again, this morning we have a lot to talk about. Our agenda today starts with our basic format. Dalton Herbal will be providing a short update of several Michigan bills under consideration that are pertinent to senior care, along with an update to some HHS federal guidance. And then we will follow with a brief situation update. This morning, we are going to take some time to talk more about visitation, since there were so many questions last week and the department held a conference call about it on Monday. And there are also a few nursing home specific topics at the end of the webinar as well. And so now we'll turn the presentation over to Dalton Herbal, our Director for Public Policy.
Good morning, everyone, and thank you for attending today's call. Today's advocacy agenda includes some brief updates about what's going on in the legislature and what will be going on for the rest of this week. They've been very busy coming up to a break at the end of September to do their thing for election season. I'll also be commenting on some updates to the FFCRA and talking about the withdrawal of the MFAR proposed rule. So what's going on in Lansing, what's going on in the legislature this week? As I said, they've been incredibly busy. This week, I believe it was on Monday, we heard that the Senate, House, and Governor have all agreed on what the budget deficit is, and that they expect to have a budget done before the 24th. Right now, there are a couple of days scheduled after the 24th in case they don't get that done, but things seem to be going well, at least for now, but it's my impression that they haven't talked about the more politically dense stuff yet. A number of bills are up, and actually even more than I have put on these slides, because a couple were added late last night to the agenda for this morning. First up, we have House Bill 5929 and Senate Bill 1021. They're in committee, and these are the reciprocity for healthcare license requirements in Canada, which essentially make Canadian education count towards Michigan healthcare licensures, or the Michigan healthcare licensure criteria, if a Canadian would like to pursue that. Usually when you see duplicate bills at the same time in both the House and the Senate, you know this is something they want to move and want to get done fast. This has been was in place from 2006 to 2012 when the original bill sunset, and so they're just looking to make this a more permanent change, because the current bill has no sunset date on it, so it would be in effect for, well, until they changed it. Next bill is Senate Bill 1094, and this is currently in the Senate Health Policy Committee, and that is going to be tomorrow. This is not a duplicate, but it resembles closely the old Lucido bill, which he wanted to have the Department of Health and Human Services create 8 regional COVID care facilities, and it would also ban the admittance or retaining COVID positive individuals in SNFs. The difference for this bill is that if you can retain those individuals if you are approved by the department or designated by the department. We understand that this would just be a self-attestation criteria, but we'll see. They haven't really, I don't believe, moved on that. And this bill was previously vetoed by the governor, so the likelihood of this getting done is pretty small. Another bill is House Bill 6124, and this is on House Family, Children, and Seniors. I believe that was yesterday afternoon, and this would create a requirement that AAAs need to conduct criminal background checks on their employees, similar to other long-term care settings. Both the department and the AAA Association supported the bill, so I expect this to move along before the end of the month. Lastly, for these slides, House Bill 6159 is in House Judiciary Committee today. This is the Healthcare Civil Liability Protection Bill for COVID-related services. We have provided testimony that CCRCs and AFCs should be included in the bill because this is a duplicate of the original bill. They weren't included in the original bill. So we have provided testimony to the committee that to please take a look into adding these two organizations. Once again, this bill was previously vetoed by the governor, similar to that Lucido bill, but they're looking to get this passed by lumping this bill in with a bunch of other liability protection bills. So we are hopeful that this will pass and we can get something done here. Moving on to the Family First Coronavirus Response Act. This slide is just a very general slide and a reminder for those on the call. This act requires employers to provide their employees with paid sick leave or expanded family medical leave for reasons related to COVID-19 until December 31st of this year. The important thing to note here is that there were exemptions included for healthcare workers, and the Department of Labor is looking to update those healthcare exemptions. So moving on to the next slide, we can see what they have updated, and they're going to be releasing this update today. These exemptions no longer apply. The healthcare exemption no longer applies to all employees employed by a healthcare provider. So those who are no longer exempt are individuals who provide services that affect but are not integrated to the direct provision of patient care. And the Department of Labor, in their early kind of summary release, cited the examples of IT professionals, building maintenance staff, human resources personnel, cooks, food service workers, record managers, consultants, and billers as those who would be no longer exempt from the act. It's my understanding the Department of Labor is doing this in response to some of the litigation they've been facing throughout the states. And an important thing to note is that the types of healthcare employers covered by the exemptions have not changed. The only thing that has changed is which employees the exemptions apply to. So it's pretty much those who provide direct patient care are the ones that the exemptions apply to. Lastly, it's just important to note that the MFAR was withdrawn. This is big news, especially for us in Michigan, as this proposed rule jeopardized state Medicaid financing structures, specifically states with provider tax programs and exemptions from those provider taxes for life plan communities or CCRCs. As you know, Michigan has both of those things. So we were one of 13 states that this rule would have hit harder than other states. So we're very excited to see that this was withdrawn. I thought some kind of cool information is that over 4,000 comments were submitted regarding the MFAR, and half of those comments were from nursing homes and or CCRCs. And then I was looking to put a photo or two of the letter Leading Age sent to MDHHS on the slides today, but their letter is actually very long in terms of copying on a slide. It's not that long of a read, it's about 10 pages. And there's a link to that down there if you're interested in the advocacy work Leading Age National is doing on your behalf.
All right. Excuse me. All right. Thank you very much for that, Dalton. Before we get to any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo during our annual conference. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. So let me go ahead and pull up the questions really quick. It looks like we just have one question right now. The first Q&A on September 4th said that you will let us know when you have more specific guidance on the permitted uses of the CARES Act nursing home infection control distribution. Is there any update on how these funds can be used?
Are we talking about the infection control prevention grants? Physical plant?
I believe so. So it's nursing home infection control distribution. in quotes.
Okay. I believe I ran over that after the 4th. I will, I don't know the specifics of how they can be used off the top of my head. I know that they, for instance, the example they provided, they can be used on things to help essentially promote infection control, but it can't be used on the actual item. So it can't be spent on PPE or hand sanitizer, but it could be spent on the hand sanitizer dispenser. So it's meant for more long-term projects. And the department is being fairly open with these funds. So if you think you have something that may qualify, they encourage you to go ahead and apply because they will lose these funds on the 31st. I will go ahead and re-look into that for the Q&A here, and I'll reach and we'll get that answer to you with more specifics.
All right, thank you, Dalton. It looks like that is the only question right now, so we can go ahead and move on, Deanna.
Okay, so now we will move on to, we have a very brief situation update for this morning. This next slide is a map of the world as published yesterday by Johns Hopkins. And Johns Hopkins pretty much has the most comprehensive and consistent data. So they're used pretty much as the state of the art, really, in terms of COVID. This heat map looks at the intensity of active cases across the world. And you can still see that the U.S. has a major proportion of active COVID cases. This next slide is another heat map for the U.S., and it identifies the intensity of cases across counties. When looking at Michigan's numbers, which are there on the right, it's important to note that we're 10th in the nation in terms of overall population. So when we look at cumulative numbers, and that we're 18th highest in cumulative cases and 38th highest in cases per 1,000 persons, we are comparatively doing pretty well. However, epidemiologists are saying that cases are still too high across the board, including in Michigan. So, while we are comparatively good in terms of caseload, we are 9th in both the number of cumulative deaths and deaths per 1,000 persons. So that's an improvement over where we were a few weeks ago. And in general, the death rate has trended up and down a little bit. But it seems like we are probably mostly in terms of our data stable, with no high caseload trends and no lower decreasing caseload trends either. These are the Johns Hopkins graphics that describe the time it takes for cumulative cases to double. And remember that in the beginning, we were talking about days in that respect, days before our caseload doubled early in the pandemic. Michigan is currently doubling its caseload about every 3 months. But note that when you look at caseload across all states, it doubles about every 4 months. So when we compare ourselves to aggregate data and not necessarily to states individually, we're still having a lot of case growth here in Michigan. Here is our standard caseload graph, and remember that these maps only include the prior 60 days. So you can see in that time that cases are not really going down when you look at the large trends. For deaths, here in the next slide, we see a little bit more variability, but also, even though it's going up and down, we're not seeing it go trend downward on a consistent basis. And here is our MyState start map as of yesterday. Again, there's been no change this week, and we continue to have a test positivity rate that is pretty stable at 3.5%. We continue to get questions about this map, basically because of the CMS guidance for nursing homes that requires testing based on county positivity rates and that are published on the Nursing Home Compare website. And we had hoped that MDHHS would put out guidance revising how they calculate the need for weekly testing for nursing homes in Michigan, but they have not done that yet. And so weekly staff testing is still required across the state based on this map currently. We do hope that when they consider the task force report, that they revise how they calculate risk in local areas because these regions are way too big. But in the interim, nursing facilities should consider the CMS guidance as the minimum expectation, but they are still required to meet a weekly testing for staff requirement from MDHHS. Last week, Nick issued some data that identified the current occupancy rates in general for several provider types. And this graphic is about skilled nursing itself. And you can see that occupancy is down to 74.8%. And that little change at the bottom shows that the decline has decreased. In other words, it's not declining so rapidly, but it did continue to decline over the last quarter. You can also see that independent living occupancy rate is averaging 85.6%, and assisted living 79.5%. All this data is through June. So now we're going to move on to visitation. We are going to discuss the current rules with a focus on the 910 epidemic order. Remember that these rules apply to all senior residential settings, both licensed and unlicensed here in Michigan. Before we go into the Michigan guidance itself, we want to note that CMS, in 2 of its recent calls, has stated that they are working on an update to the visitation rules. And this could be interesting as it could bump up against some of the state rules. So we're going to be looking closely for that to see what the CMS rules might cover to determine how this is going to all play out here in Michigan. Basically today, we're going to cover the elements for visitation that are based on Executive Order 2020-174 most recently. And then we're going to look at the epidemic orders 630 and from 910. Currently, Executive Order 174 expires on 9/30, but again, we would be surprised if they didn't extend it. Remember that the order allows MDHHS itself to refine and qualify these rules as they choose. So basically, the rule prohibits anything that's not for the provision of medical care, support of ADLs, visits related to powers of attorney or guardianship matters, visits for end-of-life care, emergencies, or anything related to governmental functions. I personally am always concerned when they use the term medical care because that implies doctors and not necessarily things like dental care. But when I first read this, I anticipated that it allowed all clinical persons, whether internal or external. And we were surprised to understand that some facilities were not allowing therapists in the building, at least for individual activities. And in terms of ADLs, I considered this that meant part of essential staff activities, anyone providing ADL care, in other words, personal care. So I was a little surprised when I realized later that they refined this with a better understanding that this had to do with visitation. And until recently, although we tried to get a lot of clarity from the state about these executive orders, we don't generally get a lot of responsiveness about the orders. But when MDHHS puts out a rule, they will clarify it, and they have been pretty responsive. So we have gotten better responses from them. Sometimes they defer back to the EO without a lot of help, but in general they do. So in that respect, it's good that they've been involved in this rulemaking because they're a lot more conversant about these provisions. So the other requirements coming from 174 is the requirement for screening and denying entry to anyone who doesn't meet the criteria, of course, the need for masks, the need to facilitate remote communications on behalf of residents. So all of that still stands. as it's written. Then comes along Epidemic Order 630, which was the department's response to the high number of complaints and concerns that they were getting from and about residents who were failing, literally failing, and sometimes dying because of isolation and loneliness during this pandemic, and of course resulting from a lot of the restrictions that have been applied. So they updated the guidance so that visits could be allowed for residents who were documented as failing without assistance from family or friends with ADLs such as feeding, other things that would help them perhaps improve their overall well-being. So as such, these visitors that could now be allowed for that must wear masks, must follow any procedures for ADL tasks that they might be performing. The visits were meant to be scheduled and specific to the provision of these tasks. They weren't supposed to be just regular visits. They had to be really focused on the need for that ADL. Those visits should be provided in private rooms or designated areas. If a private patient didn't have a private room, and the facility had to contact families to let them know that these flexibilities were now occurring in visitation. So in that guidance, they also identified that when a resident is in serious or critical condition, and they kind of widened the definition for what that meant. So anyone in hospice services, regardless of their current condition, those receiving end-of-life care, anyone whose well-being is at risk, anyone who experiences a significant adverse change. All of those persons were now included in the group that would allow indoor visits, although always, when possible, they hoped for outdoor visits. Ombudsmen, of course, were not subject to any of the visitation restrictions. So that's where we stood before last week. And following the task force recommendations, the department issued the 910 epidemic order. And that was intended to add to the 630 order. So you almost have to look at both of these orders together in order to understand them best. When you read the provisions for visiting in the 910 and the 630 order, you have to note that MDHHS is referring to both indoor visits that are allowed, those few exceptions that are allowed, as well as the outdoor visits that are now allowed through this guidance. So there are some basic requirements before outdoor visitation can be made, and the first is that you cannot have any current outbreaks. Note that the 630 order does not say that for those accepted indoor visits. And local health departments must not have designated the area as unsafe based on local conditions. And in the Monday call with MDHHS, they stated that they had alerted health departments to that new function. And so they should be used to evaluating the local environment and determining when these outdoor visits should not be required. Additionally, you must have an outdoor area with adequate protection from the weather. So that means at least providing some shade from the sun or rain protections. But we received a lot of questions about this, about tents, about screen porches and pergolas. And we would think that they would be allowed since they do provide some of that protection, as long as they're open-sided and have an external entrance. So you have to ensure that it has the feel of outdoor ventilation. Otherwise, we think that a tent that's closed would not be appropriate. So it has to be with full ventilation. Think of it that way. And these visits must be supervised. That means that someone must be in full view of the resident at all times, but that person can also monitor more than one visit at a time, and that was made clear during the call on Monday. Volunteers can be used to fulfill these roles. All these monitors, these visit monitors must be trained. but that does not mean that they have to go through a formal infection control training. But they must understand the basic safety precautions and infection control precautions that one would take during the COVID pandemic. And they also have to understand the visitation rules to oversee and ensure compliance. Since these visits can be indoors, certain of them at least can be indoors, we assume that volunteer monitors can be indoor as well. We're not sure that volunteers are now allowed for other functions. So we've submitted that question to the state among a lot of other questions that we've submitted to the state thus far. So for all of the things that the monitors are supposed to be supervising, there are a large number of provisions put forward both in the 630 guidance and the 910 guidance. And this slide includes the first half of them, more or less. And remember that these rules are almost completely duplicated in the two epidemic orders. So they do not always apply only to the outdoor visits that are now allowed, but also to those few kinds of indoor visits that are allowed. So visits must be by appointment only. You can set a reasonable time limit. They don't identify what reasonable means, but it needs to work for you and I would think the family. Visitors have to sign in and out. Only 2 persons can visit one resident at a time. Visitors have to provide contact information, and this part is new. And they have to attest that they will inform the facility if they develop symptoms within 14 days of the visit. So facilities need to create a form for this. Only visitors who agree to wear a face mask for the whole duration of the visit and adhere to social distancing rules would be allowed in. If they cannot, for any medical reasons or whatever reasons, they cannot be allowed in. The next portion is about designated entry points. Those are intended for specific indoor visits that are allowed currently. But facilities will also have to develop or create an area for screening and evaluation of visitors for these outdoor visits as well. And of course, there must be some signage posted about the need for screening of visitors. And we think that that, could be indoors or outdoors. This next slide continues the list of facility requirements. And these are all things that the facility must have in place, and the monitor or the supervisor of these visits has to pay attention to. You must make hand sanitizer and or hand washing available. So this was in the guidance for the indoor visits, but we're assuming that you could make hand sanitizer available for these outdoor visits as well. You have to ensure that you have enough staff to assist with transporting the resident to and from, monitoring during the visit itself for compliance, and of course, disinfection and cleaning of any areas after the visit. And if for some reason, and this is a little hard for me to think about, if for some reason anything more than a mask is required, the facility must provide it. So at this point, if you're requiring anything more, that implies that you have a reason to worry about transmission, and I'm not sure that that would be a case that the department would want to support a visit. But I suppose that it's possible that in the future they could have higher PPE requirements that are just standard, I don't know. But if anything more than a mask is required, the facility must provide it, and they can't deny a visit because they haven't provided it. So that's part of the rules as well. Of course, you need to let the visitors know the rules for the visit, including the need for social distancing and absolute avoidance of all contact with both staff and residents. But facilities have the right to limit the number of residents allowed to have visitors at any time, and that would be based on your space limitations. It says your infection control needs, and I'm not sure exactly what that means. That could be maybe, I'm not sure what that means, but also staff capacity. So if you don't have enough staff to monitor all these visits, you could limit the number of residents at any one time who can have visits if you can't do that. Of course, there should be no food sharing. That's not in the rule. And again, of course, you have to let families and residents know of these new updates to the rules. And no one who's in isolation or observation should be receiving visitors at any time, whether indoors or out. So those are the requirements for indoor and outdoor visitation. But there are some exceptions to the order. There are some exceptions to the actual executive order that restricts visitation. In other words, what are the circumstances that an indoor visit can be made, since outdoor visits are now allowed? So the few exceptions identified in the 630 order about ADL assistance, end of life, critical care, changes, etc., power of attorney, those all still apply. So whatever those exceptions were that were listed in the 630 order, that's the baseline. In addition to that, the department has defined medical service providers, and they're now listed as to include a wide range of clinical providers. So we now know that they're not using a restrictive definition of medical. And these are considered essential. So you don't have to think about visitation requirements when you think about these persons, because all of these people, whether they come from your staff or other staff, other contracted people, they're all considered essential. And they have to follow all the same rules as regular staff. But they do suggest that if they're coming into your facility, that visits may be made outdoors whenever feasible, but that's not a requirement that they only be outdoors. So you can have these people come indoors as long as they apply all the same rules as other staff. We have received a lot of questions about whether therapists can conduct group therapy visits right now. And we know that most visits are occurring in resident rooms for therapy, is our understanding. And last week I had a hard time answering these questions because we know a lot of facilities are doing things with residents who might be sitting far apart in their hallways, in the hall, in the doorways, etc. And so we noted that the department has not a good definition of what a group activity is, and those group activities we all know, as stated, are not allowed. But we have asked the department to better define what they mean by group activity, so that we have a better sense of what their expectations are, especially about therapy and other things that people could be done in a group, but might be done with some flexibility to provide some interaction with these residents beyond just one staff to one resident at a time. Non-medical services can be provided, but only when there's a documented negative impact without it. And because of the requirements for a medical treating professional to make that determination in the June 30, we assume that these must be identified as well for these non-medical services now allowed in this updated guidance. However, we have asked the department to clarify that as well, because it seems kind of hard to require a doctor to say that someone needs hair care. But it looks like that's what the requirement is at this point. Again, volunteers for monitoring purposes are allowed. Some have asked whether families could be volunteers so that they could see the resident. And we think that that would be difficult since volunteers would only be allowed for these specific duties. So I don't know what benefit a family member would have in supervising a family member visiting with someone else from afar. But the rule is silent about that, and so we have included that in our questions to the department to define volunteers and whether or not they can be used for other purposes other than monitoring. And last but not least, and this has caused a lot of conversation, is the concept of window visits. Our review of the guidance says that These visits must be made available for residents, all of them, not just those who have windows on the first floor that are accessible. So we assume that window visits meant a situation where a visitor who doesn't enter the building but visits through a glass window with a resident. Some of our members have asked whether this could include an indoor visit through a glass barrier. We do not believe that that's what is intended by the guidance, but again, we have submitted that question to the department. Also, someone asked whether a window visit with a screen, I'm not there yet, Blake, you want to move back? Thanks. Whether a window visit with a screen would be allowed under the outdoor visit or window rules. And we do not believe that it would be. That would open up the facility to the visitor, more or less, because there'd be open ventilation there. However, again, we've asked the department on their take on this as well. So the important things is that all the rules from the 630 epidemic guidance still apply, in addition to the ones from September 10. So you must have adequate access to testing to allow any indoor visits. That doesn't mean that you have to have testing in your building at any given time, but you need to be able to arrange for testing in case something happens to allow any indoor visits. You should always use outdoor locations for visits whenever feasible. You cannot transport residents through COVID designated spaces, and you can't allow visitors in during aerosol generating procedures or specimen collection itself. There are no visits for anyone in isolation or observation for COVID. And outdoor visits are prohibited when there is active COVID in the building. So in the last 48 hours, we've submitted an awful lot of questions to MDHHS about the guidance. And there are more questions than there are topics here. There are probably 20, 30 questions. And we've already talked a lot about these as we went through each topic. And one of the main things we talked about, and we continued in several questions, to discuss the need to separate out independent living settings and those who might be independent living with waivers, and to define their issues and rules separately from that which would be required for healthcare settings, because the situation is different and the rights and responsibilities of the facilities and residents are different. We don't know how we're going to go with that because we've made this point many times before, but we'll see how that goes. And we would like to have some clarity about the definition of routine contractor vendor visits. The department started out, MDHS started out saying that anyone with routine, or meaning weekly visits, needed to undergo testing. But then they went to 8 hours per week, and then they added having direct resident contact. And all of those statements are in their guidance at different places. So we would like them to coordinate all of that into one clarified statement, and we've asked them to do that as well. Hopefully they will. Everything else pretty much we talked about there. So I have a couple other topics before we get to questions. And that is about the updates to the HFA AFC FAQs. And that was mostly, that update was done this week, and was mostly just to include a few statements related to the new order on outdoor visits. So we're not going to spend a lot of time on these, but we're going to discuss a few highlights. Note that facilities must allow residents to return to the facility. Although if from hospitalizations or from, home stays or whatever, although if they are returning from the hospital as COVID positive, you do have some additional considerations that you can think about and apply. And the Bureau suggests that you review the hospital transfer form for options. So the link for that form is here on the slide. If for some reason you think that you have the right to discharge somebody, there are holds on discharges for certain things, mostly non-payment, I believe. But I would always check with the department before you determine you need to discharge someone. So you can refer your questions about that to the email address that is in the middle of this slide. Another thing to remember is that incident reports for HFAs, if you find you have a COVID positive resident or staff, you need to fill out that incident report and submit it. But it's not required for AFCs. I'm not sure why that is, but that is what the guidance says at this point. So this next slide covers the flexibilities for staff requirements, including CPR certifications, training, TB testing, fire drills. None of these are new. Remember also that there's no ban on new admissions, but the visitation restrictions still hold. So you really can't tour people. And you do have the right to screen or require quarantine for 14 days for new admissions, but you have to let the new residents and their family know that in advance. And if you do find the need to quarantine anyone in your facility, if you're an HFA or AFC, you should do so based on an order from the local health department. Other than that, I think that most of these points and frequently asked questions are standard and everyone's well aware of them. So now the FAQs state that HFAs and AFCs can allow outdoor visits as they're defined by the MDHHS order. Another thing to remember is that essential construction is allowed in resident areas. So if you have something break down or, you know, a wall fall down, for lack of a better example, you can allow those in resident areas in alignment with the current contractor and visitor rules. But non-essential construction continues to be banned in any direct care area. So you can only do non-essential construction if indeed it is an area that is got a significant barrier between that and direct resident care. Okay, so we've gone through this again. We had a lot of questions last time. Hopefully we can get through them if there are a lot of questions this time as well, so we're going to pause.
All right, you are correct. There are a lot of questions, so I'm just going to hop right into them. This one is decently long, so just letting you know. Earlier this summer, we interpreted the no visitors as people entering the facility, so we implemented outdoor visits in late June in assisted living and independent living. Guidelines matched closely with the new guidance that has been provided. We are struggling to police independent living, personal homes. Residents are asking if they sign a document stating they won't come into the main building, can they have visitors in their private homes? The answer has been no from us. Question, are there other organizations struggling with the same concerns?
My understanding is that there are a lot of organizations struggling with those same concerns, and actually the department is well aware of this. I think that part of their, well, they have fear. Let's just say this. They know, and we know of a few independent residential settings that had really major outbreaks, at least early during the pandemic. So they're fearful of those environments as much as they are nursing homes and assisted living. They are well aware of all of these issues, but the epidemiologists are also fearful of spread. And so all of these settings are still under the same guidance. I think one of the main issues here is the fact that while we understand that some safety precautions should be made for these residential settings, they're not healthcare settings. And so the rules as applied to a healthcare setting are harder for independent living to provide. And so if there have to be some safety precautions, they need to be in alignment with the facility responsibilities and the resident rights that are obviously allowed in these more independent settings. And we've asked for that several times. We asked for it again on Monday. It was brought up, this issue was brought up on Monday's provider call with the department. They pretty much were surprised to hear that somebody was doing outdoor visits because they're not allowed. They agreed to at least look at it, and when they put out their Q&A guidance, which hopefully will be soon, I'm hoping that they will address this in a more direct way, but we'll have to see. But I do know that everyone is struggling with this, and it's really hard.
All right, sounds good. Before we get to the next one, Dalton, are you here?
Yes.
It sounds like some people are having issues with that handout. I've had a few people say stuff about it. Is there any chance that you could, like, maybe try to rename it something different and then re-upload it? I think that maybe it has to do with
I'll give it a
the
shot.
naming. Thank you. All right, so on to the next question. Is the expectation that we are monitoring independent living residents and private homes for visitors?
So I'm assuming what this means is that you have independent living on a campus that has resident units that have separate entrance and separate entrances. That it's not a one building with a hallway with resident entrances off the building. Now, we've not ever asked that question, and it hasn't come up in a long time. But in the beginning, I at least personally considered those private homes. I did not consider them a residential congregate setting, because just because it's senior housing, it is an independent home. I didn't see any difference between that and my house. So I didn't think that those rules needed to be applied to those people, if I have an understanding of what the actual question is here. And I'm not sure how you could possibly adhere to, make those persons adhere to the visitation guidance. We did not ask this question specifically to the department. It has not been come up in months and months, but we will add that to our Q&A and ask. But I would consider those not congregate settings. So if I don't understand the question, please let me know.
Okay. Since Executive Order 179 prohibits internal and external group activities, are assisted living facilities allowed to have residents gathered in groups of 10 or fewer? We have not permitted any formal gatherings of residents, but have been told gatherings of 10 or fewer are allowed. My understanding, and there's been some confusion about this because, one of the, a few weeks ago, the governor's spokesperson said that gatherings of 10 or fewer is the only restriction for these settings, and we all know that that wasn't true. My understanding is that there's no group activities. And my thinking about this has evolved a little bit, because I do know that some people, they haven't defined group activity. And to me, we all know, we have pictures of people doing things together, far apart in hallways, with residents perhaps sitting in their doorways, etc. And, I think that keeping people in their rooms, not allowing them to do anything, I think that is, very difficult, for lack of a better word, and not necessarily helps their individual well-being. So I thought that those activities were creative. Is that defined as a group activity? Is that allowed? And when the question came up about whether or not providers could come in and do group therapy, I'm thinking, well, not probably like they did it before, but could they do some sorts of therapy and activities in the same kind of way in the hallway? I don't know. I do know that there's a blanket statement in 179 and all the preceding executive orders that says no group activities. So that's why we asked the department to define that, so that people don't have to feel like they can't allow those sorts of creative activities if indeed the department isn't going to get freaky about it. All right. And then just to follow up from that last question, they said that you did interpret it correctly and that the residents do have access to the main building to get mailboxes and other amenity areas. And it was about independent living homes. So just letting you know that.
Right. Okay, great. Great. Okay.
All right. New admits are required to be in isolation for 14 days. Does the visitor restriction for those under investigation apply to these new admits or just to those under investigation with symptoms or that we suspect may have been exposed?
Well, it does apply to them, and let me tell you why I think that it would apply to them. First of all, they're in observation. They can't come out of their room. They don't meet generally, we would not think that they would meet the criteria for any of the exceptions. I suppose it is possible that you could have someone who is at end of life, who is recently admitted, who would be in observation. I suppose there could be a couple exceptions to that rule. We've not asked this question specifically because I didn't think of it in that way. I assumed, and we assumed that the persons who are suspected and persons who are in observation are not necessarily the same thing, but we assumed that visitation would not be allowed for those persons as well, since they could have been exposed to COVID. However, that is another question that we can certainly ask the department to clarify. At this point, I don't see that visitation would be allowed for them. You certainly can't take them out of their room for outdoor visitation anyway.
Okay. Can hairdressers go to the resident rooms to get the resident and bring them down to the beauty shop? The directive says to restrict the movement of these contractors, but if they are tested, educated about infection prevention and control, and wearing PPE, how are they different from our employees?
Well, I would say that they're not. The guidance doesn't specifically say who has to do what activity in terms of making this happen. I think depending on your situation, I would probably look at this individually and look at where they would have to go through the facility and how many units they might have to go through to get people. I think I would look at this on an individual basis. Yes, that's what I would do. Remembering that you can never go through a COVID unit. You can never take the COVID people out of the unit and allow them to have these kinds of services, as long as you're applying that. But again, you know, that would be your interpretation. It's silent on it. I think that you would probably have a fairly good rationale for doing that. It might be a bit safer. I don't know what the surveyors would do. So I would look at that individually, and we can add it to our questions if indeed you want a more specific answer.
Okay. They said on Monday's call, we do not need a doctor's order for beautician services, that the staff can determine if they feel not having the services is detrimental to them.
Great, great. I did not hear that. I'll have to admit I did not hear that. That is wonderful because I think it's ridiculous.
Okay. They were clear on the call this week that a doctor's order was not needed for non-medical providers, said it could be staff documentation. I thought that was addressed on the phone call with MDHHS.
Wow. Okay. So I might have missed that. I will update our information accordingly.
All right.
I think that's great.
If resident is end of life, can visits still take place when facility under 14-day isolation due to positive staff member during testing?
That is what we just discussed as a possibility, and I don't have a good answer for that. I would be compelled to think that persons should visit, especially if you don't have a positive COVID diagnosis or you don't have any symptoms of COVID and you're simply under observation. I would think that an end-of-life visit would be appropriate, but we will ask.
Okay. I called our local fire department and was directed to our local fire marshal, who told me that the propane heaters are prohibited unless the tent is NFPA flame spread rated.
Oh, okay. The department, I understand, is looking for additional guidance about heaters, and we have submitted a question about whether or not this is a local issue as opposed to a Bureau of Fire Safety issue, since a lot of these facilities are unlicensed and are not inspected by BFS. So we anticipate some guidance from them. I did anticipate that there might be some difficulties with heaters, but I'm not an expert on fire and life safety code issues at all. So I'm not surprised that there would be some additional requirements before you could use them. But we will put that comment in our Q&A. And I want to remind everyone as well that we did not specifically send the visitation Q&A out with the webinar yet. We will do that, but we did send it out in our update as with a summary of all of the visitation guidance. So if you're looking for answers to the Q&A from last Friday, look at our updates that have come out. They are included there.
Okay. If for purposes of window visits we used a vacant first floor unit for the resident to be in, would we be required to provide shelter for the visitor outside the window?
I don't think there's any requirement that you provide shelter, and I think that people have been doing this, and I don't think that they necessarily have done that. It might be a nicety, but I don't think it's required. You just have to remember that if you're using a vacant room, I think that works really well, but you have to probably disinfect it and clean it after every visit.
Okay. Now that testing is recommended for HFA, how are we supposed to address those that may be positive if we do not have a dedicated COVID unit?
That's a really good question. And I don't have a good answer for that. Let's wait until we talk about testing coming up.
Okay. What is this incident report that was referenced for HFAs to submit if outbreak? Is this the usual state reportable form or a different form?
My understanding is this is the normal state reportable form. And I don't have a lot of experience with this. I just noted that it was in the Q&A, and it just seemed odd to me that AFCs are not required to do that, but HFAs are. So I just wanted to remind everyone of that requirement. My understanding is that it's the usual process.
Okay. Is the CPR guidance the same for SNFs right now too, or just HFA AFC?
It's the same for SNFs.
Okay. Did the department provide clarification on facility-acquired cases? What if the person was infected with a known external exposure? Is there a difference?
I'm not sure exactly what the question is. If you are asking whether or not you have to deny outdoor visitation because you have a non-facility acquired case, you do not. It's only facility acquired cases that they're concerned about where there might have been some transmission. So they're concerned about outbreaks in the facility that could have occurred because of any potential breaks in safety precautions. They are not concerned about people who come in with a known diagnosis or who develop a diagnosis within 14 days of their admission. So I'm not sure if that answered the question. I'm not 100% sure what the question was, but if not, let me know.
Can you confirm that non-essential construction is also banned in SNFs? Are only emergency repairs allowed?
Yes, that's for all settings.
Okay, so we should not allow volunteers until further guidance is provided?
I'm thinking that if you have been doing it, you know, the guidance hasn't been very clear about that all along. And I think if you have been doing it, you know, you might, I mean, I don't know what the point would be quitting. I hope that they respond to that question in a meaningful way, because the state doesn't always. Sometimes they'll come back and say, well, we refer you to blah, 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 and that doesn't help at all, because that's what the question was about. But hopefully they'll respond. Whether or not, if you have been allowing volunteers in for other purposes, you know, it's your decision about whether or not you should continue it or not. In the interim, I don't know whether it'd be meaningful if you stopped it, because you've been doing it. It's up to you.
Okay. New admissions are in isolation to protect others in the building, not themselves, so it seems like they could visit with the family that admitted them for ADL purposes.
I would think that too, but I don't know what the state will think about it, which is not always the same thing. But I agree.
Okay. If we can send the question regarding beauticians going to resident rooms, since they are tested, screened, educated, and wearing PPE, we would appreciate that. Thank you.
Oh, certainly. Certainly we will. Although I do have to tell you that we have overloaded them with the number of questions, so I'm fearful that's going to take a while, because they have to check with 15,000 people in order to make a decision. But we will continue to ask these questions and see what we get.
Okay. I have a client with whom I have been permitted to visit throughout the quarantine. The problem is that he cannot hear me when I am wearing a mask because he relies on lip reading for comprehension. He demands I remove it, short of ensuring I am 6+ feet away from him, and document his insistence. Is there anything more I should be doing to protect myself and him?
Well, masks are not required for people who cannot tolerate it. So I would think that the same kind of thinking would apply here. I would move back 6 feet. And for your protection, I would ask that if the resident isn't using a mask, that they're using a mask as well. I can't. What about a face shield, though? I would think that maybe a face shield would provide some protection and allow him to see your face, him or her to see your face. So that might be an option that you might use. But if someone needs services, I certainly think that you should probably attempt to work around it. And I think that calling the local health department would be a wise thing to see if they have any additional guidance.
Okay, we had a couple people send suggestions in. Get a mask with the plastic mouth that is visual. SLP uses this type of mask too. They sell these on Amazon. There are also face masks with windows that are available, used from hearing impaired who read lips or sign.
Great, I had not known that. Great.
Okay. Are facilities requiring the COVID test 72 hours prior to admission?
Nursing homes. If the question is whether or not a nursing home is required to ensure that on admission a person's testing. It isn't that they have the right to require a hospital or some other entity to do a test within 72 hours. The requirement is that they test on admission. The exception to that is if it's been done 72 hours prior. If requiring it, let's say if you're looking at all of your new admissions and you want to require a test within 72 hours, it basically doesn't provide any more information than the state of that person's potential viral load as of that snapshot in time. So we all know that the incubation period is longer than that, and a person could test positive later. It just provides that one piece of information. I suppose that people could require it, but remember, you're not allowed to hold up a discharge from a hospital simply because of lack of testing. And you are required to make sure that they are tested by admission. If not, on admission, they must have had a previous test within 72 hours prior. I'm hoping that answers your question.
Would volunteers be tested weekly?
I would think that anyone who comes in the building on a routine basis, you can use the weekly rule, the 8-hour rule, or whatever, or the direct resident care rule until we get any clarification about that. But yes, I would think that they would meet the criteria for that as well.
All right, and then I'm going to go back to one question because they came back and kind of added a couple more things to clarify.
Okay.
The original question was the one that says, did the department provide clarification on facility acquired cases? What if the person was infected with a known external exposure? Is there a difference? To clarify, some staff may contract the illness from a family member and may not have exposed anyone at work. What about staff who did not have a facility acquired exposure?
CDC, CMS, and MDHHS consider pretty much any staff COVID positive persons in your building who are working in your building as an outbreak. And so you have to act as if they are an outbreak. Unless, and the only time is, it doesn't matter if you know where they got it. If they were working in your facility, you cannot be sure that they didn't infect anyone else. So unless you know that they have not worked, and this is the part where there's a little bit of confusion. I think one guidance says, as long as they haven't worked within 72 hours before symptoms and or test, or 14 days before symptoms and or test. There's some confusion about that. But if they have been working in your facility, while they could potentially have exposed someone, you have to consider that as an outbreak, and that would be considered a facility acquired case.
All right, thank you, Deanna. It looks like that was the last question for now, so we can go ahead and move on.
Okay, and we'll try and do this quickly because I know we're running late. There are a few additional guidance. This next one is the one we were just talking about. MDHHS supports testing in homes for the aged. So yesterday, they issued notice that they will support, meaning that they will reimburse homes for the aged. And in order to get this reimbursement, the facility must be licensed as an HFA, to take advantage of this. Note that they're only supporting diagnostic kinds of testing. They're not supporting the kind of testing that nursing homes conduct for staff on a weekly basis. And these are just recommendations. They're not requiring the testing, but they are encouraging it, and they will reimburse for certain amounts of it if you choose to do the testing. So the situations for testing, which are listed here, they're pretty much the same for nursing homes, with the exception of that weekly staff testing for screening purposes part. Tests can be PCR and antigen, and this is where the guidance gets confusing. Although they allow point of care testing, they don't seem to identify that the facility could possibly be doing it. They suggested that there were two alternatives to how to get their testing done. Either a lab be contracted to do it, or the state could do it. And the state does have a lot of forms of assistance for this sort of thing. And they're requiring a physician order. And last week we learned for a CLIA wave test, which is what the point of care test is, supposedly we don't need an order in Michigan to do that. So there's a lot of questions about this to be answered by MDHHS until we fully understand it. And we'll be submitting those questions. We've not done it yet. This guidance came out like late yesterday afternoon. But MDHHS will reimburse for any testing that's not covered by insurance. So Blake, while I'm going through this, will you find the HFA testing question that I wanted to hold until we went through this, and then at the end ask it again. Anyway, so the department will provide assistance.
Which one was it? I'm sorry.
Hello? The HFA testing guidance, and I said we'll talk about that after we go through it.
All right, I'll try to find it.
So look for that. Anyway, so they're going to provide assistance for testing, or you can manage it yourself. But again, the guidance seems to imply that you should contract with a lab to do it. And the POC test, while it provides rapid results, it loses some of its usability if you have to wait for a lab person to come and do it. So we're going to seek clarity on all of that. There are a lot of support documents in this guidance with links, and so we've made the guidance as part of our handouts, and that's the piece that Dalton was trying to make work for people, rather than try to put all the links in this slide. Pretty much, the HFA guidance mirrors the state guidance, except for the fact about who can do POC testing and the reimbursement for staff screening testing on a weekly basis. Except for those two pieces, it's very close to the nursing home guidance. You do need to note that reimbursement, I think you can move to the next slide. Thanks. That reimbursement is through an agency called Sigma. And this is generally used by Medicaid providers. And if you don't have an account with them, you should look into that. And that link is in the handout. And the other documents that I've listed here, the reimbursement form, the list of laboratories, the financial guidance, etc. Those are all links that are in the testing guidance that we have attached to the handouts. So another thing is that the guidelines suggest that you address resident refusals for testing the same as nursing homes would, and the state has put out some suggestions and guidance for that. So there's also a link to the nursing home guidance for this for you to review in that handout as well. Reporting, we still have some questions about reporting, period. If a laboratory does it, they're going to meet all the laboratory reporting requirements, obviously. Reporting for testing for SNFs, we're still kind of trying to work through. There's still some questions about that. However, it doesn't seem that there's additional reporting required other than positives to your local health department and all cases through EM resource at this point, at least. So that's kind of where we are in terms of HFA testing. What is the question that you have then, Blake? Did you find that?
I believe I did. I think that it was, now that testing is recommended for HFA, how are we supposed to address those that may be positive if we do not have a dedicated COVID unit? Was that it?
Yes, that's it. I believe that if you do not have the ability to adequately care for someone who's COVID positive, be they symptomatic or non-symptomatic. The guidance actually says, 179 actually says that you have to attempt. If you don't believe that you can care for them, I would reach out to the department. You can do that through us if needed. And we will try to get an exception. There have been some exceptions made to placement in regional hubs by assisted living if it's absolutely needed. If you believe that you can, you're supposed to attempt to move them to a safer place. But if that doesn't work and you believe that you can care for them, I think at this point you should do so. The thing is that while the guidance seems explicit, it isn't very practical. And there are exceptions that occur to this all the time. And the state has been very helpful when we come up with a problem that doesn't seem to work. So either contact MDHHS, they have a COVID piece. You can call the state health department. You can call your local health department, which is probably the first call you should make if you decide that you need to transfer a person out. I know that that isn't very clear in terms of alternatives. It would depend on kind of your case situation, but it's because, you know, the guidance itself is not very practical. Okay, can we move on now very quickly? The next 3 slides, and I'm not going to go through them thoroughly at all. I just wanted to remind everyone what the trainings are that are available. There's CDC trainings, and these are all of the topics listed here. These can all be accessed through the website below. I think that there's a lot of good trainings here. The nursing home infection preventionist training is very detailed and very good. It's a little arduous, but it is a good review for not only infection control staff, but also nursing management, so you might consider that. Next slide. These are all of the CMS trainings that are available mostly through the QIO. I've listed them here for you if you're interested. You can access all of them through the link below. I think cohorting strategies is one of the better ones if you're interested in looking at some ideas about cohorting. CMS trainings, there's some additional here. They're also available through the QIO website. And especially the CMS CDC live Q&A sessions, they are held every other Thursday at 4 p.m. The 2 topics coming up are accepting new patients and establishing a dedicated COVID care center. I think that those are both probably pretty pertinent. Training fundamentals, again, you can access all of these using the link below.
All right.
So,
thank you, Deanna. We do have a couple questions.
okay.
Is this only for HFA or AFC as well?
It is not for AFCs. I'm not sure why, but it is listed specifically that you must be licensed as an HFA, and it even identifies the document, the law that provides those licensing requirements for HFAs.
Okay. If you elect not to do HFA testing, wouldn't this look bad for your community? If you have an outbreak, wouldn't not doing this be ill-advised?
I don't know whether it looked bad or not, but the reality is that if you think about the frailty of your population, the kinds of problems that they tend to have, the fact that you have staff moving in and out of them, just like a nursing home in areas of relatively high transmission, yes, I think it would be prudent to take them up on testing. It's true that you might find asymptomatic staff now and then if you're doing staff and residents for any reason. You may find asymptomatic residents and have to deal with that, but I think in terms of prudence and the fact that it's so contagious that would be the thing to do.
Okay. Do we know why the testing guidance did not also include AFCs, and can we expect that to be next?
I don't know. We'll have to talk to the department about that. We were given a few hour heads up. In fact, I was just about to put out that we anticipate this guidance before we could even get it out, that it was coming down the road. We heard that it had been issued. So we did not have a chance to really discuss this with the state. We can do that in the near future.
All right. And then I have seen a couple people talk about not being able to access the handouts or specifically the slides now. So I'm just going to pull this over and show you guys again. Just a quick reminder, if you can't seem to access anything or get it, you can just go to our leadingagemi.org site. You'll see this banner right here. You can click on that. You'll scroll down until you see this previous webinars, and this has the date and recording, the PowerPoint, and then the Q&A document for every webinar that we've done so far. So right now we have 9/11, and we will be putting up today's recording and PowerPoint once we get those finalized. So just wanted to remind everybody of that. And I do not have any other questions right now.
Okay, so very quickly what we'll do is we'll finish the few topics that we have for SNPs only. I just wanted to alert everyone, if they weren't aware, that they are considering a SNF QRP, healthcare-associated infections that require hospitalization measure. Healthcare-associated infections are, of course, those infections that are acquired while receiving a facility, not present on admission and not incubating at the time of admission either. So they are generally considered potentially preventable, and of course they have negative impact on the consumer and increased cost and economic burden. So although they are considered potentially preventable, they're not considered never events. So that the goal is to identify a facility's performance in comparison to others. So there is a very complicated measure here. Most of them are these days. Basically, there's some exceptions, but they're going to count the number of infected persons going back to the hospital from your facility, unless they came in and developed it within 4 days, and through 3 days post-discharge from your facility. They will identify chronic infections and identify those kinds of infections that take long times to present. And they're going to do this through looking at the principal diagnosis code on the rehospitalization claim as present on admission. That's the qualifying piece. And the denominator for this will be all Medicare fee-for-service SNF stay, except for, of course, stays less than 4 days, or those that have had no hospital stay within 30 days, incomplete data, and all of this, the denominator is heavily risk adjusted with things like age, sex, other things. So this rule, you can move the slide. This rule has just been issued. They're taking public comments at this time. We also want to note that there's some data challenges. Health inspection data has been held constant since March. 5-star data is based on last year, Q4. We don't anticipate QM data is going to be updated, and we also think that it's possible that they might update inspection data depending on what they have, but it might not be updated in October, and that's when they usually do the major updates. So Leading Age Insights, which which members have access to in order to evaluate their data and other, probably won't be updated for a while. They're going to look at it after the October review, and if they see some data shifts that might be important to look at, they will do that. And you can access Leading Age Insights through our website, and this tells you how to do it. So we're done for the day. Any other further questions?
It does not look like I am seeing any other questions, so if you do have any question pop up after the webinar, we have Deanna's, Dalton's, and Laura Funch's emails there, as well as the Safe and Calm, so you can go ahead and shoot your question off there, and we'll make sure to get that answered for you. We would also like to just thank Deanna and Dalton for everything today, and we would also like to thank, I believe we had around 85 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. I don't think I really have anything else to say. I hope everyone has a great rest of the day. Deanna or Dalton, do you have anything else you'd like to add?
Have a good day, everyone.
Have a good day.
All right, thank you, and we will see you all on Friday.